I'd like to introduce the UBC Centre for Migration Studies. Please follow us on Twitter. Our Twitter handle should be up shortly, and if it isn't, it is at UBC Migration. My name is Nancy Clark, and I would like to also acknowledge that we are gathered today on the unceded, traditional, ancestral territory of the Musqueam people. Please remember to use the chat function or raise your hand if you have a question, and we will convene after the presentation. It is now my pleasure to introduce Dr. Denise L. Spitzer. Dr. Spitzer is a professor in the School of Public Health at the University of Alberta and an adjunct professor in the Institute of Feminist Gender Studies at the University of Ottawa, where from 2005 and 2015, she was the Canada Research Chair in Gender, Migration and Health, and as a principal scientist at the Institute of Population Health. In addition to undergraduate studies in biology, Chinese language, and music, she also holds a master's degree and doctorate in anthropology from the University of Alberta. Dr. Spitzer is interested in examining how global processes intersecting with gender, racialization, migration status, and other social identifiers are implicated in health and well-being. Her current program of research focuses on the impact of the global economy on immigrants, migrants, and refugees in different parts of the globe. Critical perspectives of the body, transnationalism, constructions of identity, the impact of policy on health and well-being, community-based participatory research, and intersectional analysis. Professor Spitzer has published in journals such as the British Medical Journal, Gender and Society, Medical Anthropology Quarterly, and the Canadian Journal of Public Health. Her edited collection, Engendering Migrant Health, Canadian Perspectives, was published by the University of Toronto Press in 2011 and was listed amongst the top policy books by the Hill Times and was recognized by Women's and Gender Studies Association in 2013 with the Outstanding Scholarship Citation. When she's not working, Dr. Spitzer, also Denise, reads copious amounts of fiction, sings, watches old movies, and plays with her intelligent, adorable, and talented feline, Sophie Cat Spitzer. Welcome, Dr. Spitzer.
Thank you, Dr. Clark. And I would add that Sophie's also charming in addition to all those other attributes. So I thank all of you for attending today. I thank also Dr. Clark and the UBC Centre for Migration Studies for this opportunity to speak with you. And a particular shout out to Douglas, Emily, and Atia for helping us get organized today. Oops. Interestingly, this is, sorry, just having some slide fun. Okay. Today, I'd like to share some thoughts regarding intersectionality and what this lens can do for our work on migrant health. Although I work at the University of Alberta, which is located on Treaty 6 lands, I'm joining you today from Ottawa, from the unceded Algonquin Anishinaabe territory. So, the fun begins with the To begin, I'd like to provide you with a bit of an overview of my remarks today. I'll begin, not surprisingly, with an introduction. And basically, the overarching goal of my presentation is to argue that intersectionality is critical to reframing our thinking and our action on the promotion of migrant health and health equity. So after providing you with a very brief overview of intersectionality, I will muse about some of the complications and perhaps some of the ways in which we conceptualize intersectionality in ways that address some of the challenges that we use in applying the lens. Next, I'll review how intersectionality works to nuance, and I think therefore makes more relevance and more effective our work on migrant health. And finally, I conclude with thoughts about how we can move forward in situating intersectionality in migrant health. And of course, we'll end with our Q&A. So while the term intersectionality was brought forward into the lexicon by Kimberlé Crenshaw in 1989, as she articulated the struggles that Black women workers faced when they found that policies that focused solely on racism and sexism did not really address their issues. Notably, these policies failed to account for the simultaneity and the interlinked oppressions that operated together, which were implicated in their status and in the conditions they were facing. Importantly, though, even though this concept was coined in 1989, prior to its naming, the ideas could be found in various articulations in Black, Indigenous, queer, and post-colonial feminisms, which sought to illuminate the multiplicity of interacting categories of social differentiation that inform lived experience. Elena Hamkimsky, the founder and director of the Institute for Intersectionality Research and Policy at Simon Fraser University, in describing intersectionality, writes that human experiences cannot be adequately understood by prioritizing any one single factor or constellation of factors. Social categories such as race, ethnicity, gender, class, sexuality, and ability are socially constructed, fluid, and flexible. And social locations are inseparable and shaped by the interacting and mutually constituting social processes and structures that are influenced by time and place. And to these social categories that she outlines here, which of course are not meant to be exhaustive, I would add for our purposes, migrant status, age, indigeneity, geography, and so forth. All of these axes of social differentiation have their attendant power relations and are contextualized by historical and contemporary systems of colonialism, neocolonialism, and globalization that further situate individuals and communities within the social landscape. Intersectionality differs from other and previous approaches understanding social differentiation. So even though many of those attempts to understand social differentiation were increasingly progressive, and I have to say I am old enough to remember when we even fought for acknowledgement that gender was an issue we had to struggle with, at least in the health and scientific fields. Many of the times we began to focus firstly on gender and then solely on perhaps one or two other markers such as gender and socioeconomic class, or gender, socioeconomic class, and racialized status. But often these were presented in an additive framework. Intersectionality is in fact grounded in the notion that the multiple dimensions of social life cannot be segregated, and again, that they are mutually constituted and they are fluid. For example, ascriptions and expectations of gender may differ according to class, ethnicity, or sexuality, among other things, and certainly the interaction of all of these categories produces singularly different outcomes. Moreover, intersectionality challenges a priori ahistorical categorizations and demands attention as to the current structural and historical processes that shape social categories and confer specific status on them. Think, for instance, how sexuality as a category has changed over the past 50 years in Canada alone, what contributed to those changes, and what those implications are for disparate genders, ethnicities, classes, etc. Think as well about the legacies of slavery, colonialism, and neocolonialism, and their entanglements with constructions of racialized categories and their impacts on migration patterns. Furthermore, intersectionality does not necessarily privilege a particular axis of difference. And often we find that still people use gender as a primary category upon which to integrate other axes of the social differentiation. In the work I've been doing actually with some of the HIV positive Indigenous women using arts-based methods to describe positive aspects of their health, it's in fact indigeneity, not gender nor disease status, that is central to their identity and which most prominently informs gender and health. Intersectionality encourages us to examine the totality of interacting categories, which is how we are presented to the world and how we respond to it. I don't get to do my gender thing here, my whiteness thing there, my old sarcastic Jewish thing somewhere else. I am all of those things in different measures at all times together in different contexts. And depending upon that context, I am conferred and experience varying degrees of both oppression and of privilege. And again, it is this critical element which I think makes intersectionality an extremely important lens. So in essence, intersectionality is about who we are in relation to others, given our backgrounds, our histories, and our present contexts. Now, allow me for a moment to take a brief detour. When we present on intersectionality, we often search for visual metaphors to convey the concept more vividly. And frequently we see a traffic crossroads or a clover leaf or interlocked fingers of differently hued hands. And try as they might, these images do not adequately portray the kinetic, interactive, and shifting nature of intersectionality. I've mused perhaps that maybe a lava lamp would be useful imagery. Now, for those of you not of a certain age, although I understand they're having a bit of a comeback, a lava lamp was a cylindrical object, or is one, I should say, that contains illuminated, multicolored, viscous material. I think it's actually wax, which aggregates and comes apart. And so it's a bit mesmerizing, and it conveys fluidity and different constellations of colors and materials and densities. But I've set the lava lamp idea aside, and I think for the time being have settled on the idea that we can think about a kaleidoscope, an optical instrument with colored beads whose constellations shift with each turn. While it's not a perfect metaphor, it still speaks to how the same elements, in this case, we can imagine social identifiers such as gender, class, ethnicity, migration status, etc., come together in different ways and produce different images when cast in different lights. While it too does not allow for the representation of the kind of dynamic interpenetration of social categories, the turn of the kaleidoscope at least gestures towards some form of movement. And if I'm going to stretch the metaphor to the outer reaches, which obviously I will, I might even suggest that the cylinder represents the kind of macro level forces that structures those constellations, those forces of things like political economy, globalization, global division of labor, and so forth. And if that doesn't work as a metaphor, it's still kind of nice to look at. Hence my use of this kaleidoscope image today. So in addition to the macro level forces that I've mentioned, when we think about intersectionality, we need to also think about the interpenetrating mesolevel factors, such as policies, services, and institutions, and the micro level factors, family, household, the body, and resistance that further configure one's place in the social landscape. Intersectional status, in fact, positions individuals and communities within social hierarchies, where we experience individual and collective interactions with physical and social environments. Our social location influences exposure to biopsychosocial insults, such as racism, sexism, homophobia, and other forms of discrimination and exclusion, and shapes our access to personal and social resources with which to withstand them, all of which contribute to differentiated health outcomes. Intersectionality, therefore, allows us to unpack the tangled relationships amongst social location and social structures that underpin health disparities. As such, intersectionality can extend and lend nuance and dynamism to a social determinants of health approach, which in turn, I think, helps to maintain focus on structural issues when we're talking about intersectionality. Moreover, given its focus, it also lends itself well to considerations of policy and structural change. Also, because it deals with the nexus of interactive axes of social differentiation and how these effects position individuals in the social landscape, intersectionality can also be placed in conversation with work that focuses on the body and embodiment. And I will attempt to kind of bring all of these elements, social determinants of health, embodiment, and policy, to bear on my discussion of migrant health and intersectionality. While I believe that intersectionality can make a critical contribution to our understanding of ourselves and of others, there are both ways the concept will continue to evolve and also ways in which we have to contend with the challenges that it brings forward, especially when we are actually applying it. Moreover, firstly, I think, in the quote of Elena Hankivsky's, she makes reference to space and time. But I think in general, temporal and spatial dimensions of intersectionality are not always adequately addressed. Our intersectional status does situate us in the social landscape. In fact, we all belong to multiple social landscapes on which differ, I think, across both time and space. So for example, when I worked with mature Somali refugee women in Toronto many years ago, they were regarded by most observers outside of their community as poor, unskilled, benighted refugee women. And in fact, they were treated as such when they went out to work or when they did errands in Greater Toronto. But when they returned to the cluster of apartment towers where many Somali refugees were concentrated at the time, their social positioning changed, and they were revered, wise women. So yes, all the elements of their identities were the same. They were like the colored beads in that kaleidoscope, but in a different light, in a different setting, they assumed a different meaning. And they were women, as older women, considered to be revered, respected, and treated with great kindness. What one woman told me, at home I was a queen, but here I'm a chicken, in reference to her social positioning in Somalia versus Canada. She just have well been reflecting on the shift in status that she experienced almost on a daily basis that changed again over time and space. And when we think about it over the long term, all of us age, people may migrate, people have altered ability, and people may become upwardly and downwardly mobile. So also changing one's intersectional status over time. So I think it's important that we always maintain attention to the dynamics, and not just the dynamics, but also the direction of those dynamics when we're thinking about intersectionality. Also, an important issue that requires an ongoing attention is the tendency for intersectional analysis to focus on the individual. And in this case, we risk losing the historicity and the social context of one's social location. This issue, I think, is particularly problematic where we consider health issues, because we know that biomedicine is inherently reductionist, and it's quite easy for us to fall into, again, a focus on the individual. Notably, intersectionality is messy business. It's fluid, it's dynamic, and perhaps as I alluded to in my struggle with trying to find a visual metaphor for it, the dynamism and ultimately the slipperiness of the concept, which in fact for me makes it particularly useful and particularly rich, becomes freeze-framed when we communicate. So capturing intersectionality is also extremely difficult when we think about the enormity of issues that can be sort of captured in terms of social categories that comprise us. And so this compels us sometimes when we are doing research or doing work to set boundaries around which of those social categories to which we can attend, but can of course lead us back to the whole notion of the expert or the researcher or the health professional as the arbiter of which factors are privileged. And that's something, of course, that the embrace of intersectionality was truly meant to avoid. Additionally, we need to, there has been a kind of movement, I think, to use intersectionality as another buzzword. In the same way that when we first started to talk about gender, we saw people talking about thinking that it was somehow an updated version of the word sex. And so I think that we have to be very cautious about how people are applying the term to ensure that people are in fact using the concept in the way in which it has been conceptualized. So for instance, I recently read a systematic review of the literature on intersectionality in higher education research. And the authors found that most of the people who were deploying intersectionality used an additive approach that highlighted only two dimensions of social identity, generally gender and racialized status. And again, those two axes were identified by the researchers who consider them most salient. So, end of introduction. Let's talk about migrant health. Highlighting migrant status as a constellation of social markers that comprise intersectional status surfaces an individual's backstory. This includes home country and familial contexts, reasons for and the nature of migration, the migratory journey, reception of host society, shifting gender and other social roles, mobility in socioeconomic and employment status, changing resources and conditions of social support, which, among other issues, impact access to determinants of health and produces different health outcomes. Another critical element of migrant health that demands consideration is, in fact, migrant status. Migrants are situated or sometimes inserted, not necessarily by themselves, into temporary, permanent, or undocumented categories, all of which affect their differential exposure to risks and access to health determinants. Notably, these migrant categories are often determined by gendered and racialized divisions of labor. In many countries, of course, skilled professionals and investors, often men of higher socioeconomic class, are eligible for permanent resettlement, whereas domestic and agricultural workers and laborers, primarily racialized women and men, are prohibited from settling in areas where they may have lived for years as non-permanent workers. And again, this is the case very much in Canada as well. Moreover, status may change, say from temporary to permanent, or it can fluctuate between temporary and undocumented statuses. And intersectionality, I think, can help illuminate the influence of the policies, programs, discourses, and values that are implicated in all of these stories and all of these changes in status. Most immigrants, or migrants, I should say, arrive in their destination countries in better health than the resident population. However, there is a trend where they may lose this advantage over time. While the loss of the healthy immigrant effect, as is named, was first attributed to changes in diet or adoption of unhealthy behaviors, is in fact social issues that are most apt to underpin this phenomenon. And notably, this is not a uniform trend. The loss of health status is most precipitous amongst racialized women. Not surprisingly, these are people who are overrepresented in low-wage employment and often subject to de-skilling. Even well-educated professionals are vulnerable to downward mobility, which in itself is associated with deleterious health effects. Now, social support can help mitigate against these negative effects, but depending upon migration status and, in fact, often economic wherewithal, family unification may be delayed or denied, resulting in a loss or lack of social support, which again is in itself a well-documented determinant of health. It also means the intensification of worries about the well-being of family in their country, which it also contributes to further stress disorders. Specifically, migrants are overrepresented in precarious work, again, characterized by low wages, poor occupational safety measures, job insecurity, lack of control over work processes, and exclusion from protective legislation. All of which, again, contribute to deleterious health outcomes. As we are witnessing in the current pandemic, which has laid bare some of the egregious inequities lived by migrants who work in slaughterhouses, factories, and farms to produce our food and who service our deliveries, overcrowded migrant workplaces and residences greatly enhances risk of contracting infectious diseases. These issues are particularly salient where people are confined to their workplaces, places like fishing boats, farms, and private households, and or where they are reliant on employers for food and access to healthcare and, again, social support, or where they are often subject to constant surveillance. I work a lot in Hong Kong with Filipino and Indonesian migrants, and particularly migrant domestic workers. And many of them are talking about how the pandemic has led to a vastly increased workload. Moreover, they're facing lack of masks and hand sanitizers, things that their employers won't provide, and demands that they remain in their workplaces on their single rest day, isolating them from friends and making it more difficult sometimes for them to actually send remittances back home to their families, which is the reason they migrated in the first place. Moreover, migrant workers have been scapegoated as carriers of contagion, and some of them have complained that when they do go out, they face opprobrium and scrutiny from the public, and also harassment from the local police when they venture outside. Moreover, many of them are involved in, engaged in really a great amount of worry, which is again a highly gendered labor that's further intensified. They worry, like others, about their families. They worry about encounters with racism and about contracting coronavirus. In Canada, migrants are overrepresented both amongst the ranks of the workers who are deemed essential and among those most affected by pandemic-related closures. Public health measures have contributed to fluctuations in migration status. Work permits cannot be easily renewed if someone is in quarantine or lockdown, or if the office, in fact, is closed. The loss of documented status has cascading effects that engender stress on those migrant bodies. And the effects of precarious migration status and precarious work are exacerbated by conditions external to paid labor. So that the dynamics of downward social mobility and changes to gendered household roles, including parenting or breadwinning responsibilities, some of which challenge traditional gender identities or compel individuals to assume additional tasks, have significant repercussions for health and well-being. Overall, these experiences are written on and responded to by the body in the form of symptoms that may be intelligible as disease, such as hypertension or depression, or others that may be expressed as an amorphous set of sensations that define nosological categorization, something that I term the embodiment of inequality. When I conducted research with Chilean migrant women about their maturation experiences a number of years ago, women described symptoms such as insomnia, headaches, and heart palpitations. These were, of course, interpreted by physicians as menopause. However, the research participants rejected this diagnosis. They, in fact, related these sensations to their experiences as migrants, and specifically as political refugees. Women who in Chile had been students or professionals, but who are now in midlife experiencing the long-term effects of the downward mobility they underwent when they fled the military junta. Often this engendered worries about the financial security of their families, and also engendered marital problems because some of their partners had a more difficult time coping with this loss of status. When they spoke to other Chilean friends, they understood the meaning of these symptoms as responses to past and current injuries, which were, of course, not grasped by the medical doctors who would write them prescriptions for hormone replacement therapy that remained unfilled. One woman did tell me, though, that her symptoms abated when she kicked out her husband, suggesting another form of HRT, husband replacement therapy. But I don't know if you can actually get a prescription for it or if it would work for everyone, but it certainly seemed to help her. Anyways, despite the complexity of these embodied personal and social nature of the complaints, biomedicine focuses attention on the individual and is predicated on uncovering proximate causes or a single etiology to link to a single disease label. The effects of social inequality, a patient's life trajectory, and the broader social context in which they are situated are effectively erased. Yet health outcomes are considerably more complicated. I'm reminded of a study I read many years ago by the American anthropologist William Dressler, who explored the long identified relationship between African Americans and hypertension, which, kind of like the loss of the healthy immigrant effect, was attributed first to diet and then later to poverty. But the epidemiological data at the time didn't bear out those assumptions. Dressler kept unpacking the data and discovered, in fact, that darker-skinned, higher-educated African Americans reported the higher rates of depression and hypertension. Well, why this group? They had certainly been taught to get a good job, you must get a good education. But racism, which had a more discernible impact on darker-skinned individuals, frustrated their ambitions. And the disparity between what they had expected because of what they had worked towards and the reality in which they found themselves had negative health impacts. Although Dressler's work predates the coining of the term, his approach illustrates not only the poverty of the reductionist approach, but also how an intersectional analysis can sensitize our understanding of how axes of social differentiation interact in sometimes surprising ways. And what is critical is to identify their relationships to individual and collective identities, behaviors, and health outcomes. Now, returning to the migrants, most migrant health programs and policies target specific health conditions and outcomes, often focusing on so-called risk factors, rather than upstream factors that could change the shape of the system. Efforts to address disparities in migrant health and the diversity amongst migrant populations are generally focused on encounters with healthcare professionals. But these encounters and these interactions are not neutral. They are a reflection, like all of our institutions, as of society writ large, and they are embedded in systems of racism along with other forms of discrimination based on gender, sexuality, disability, religion, age, etc., that structure opportunity and engender inequality. At present, we find that there are myriad media and political narratives that link migration to terrorism, insecurity, contagion, and other social ills that we've found have hardened attitudes towards marginalized migrant populations around the world. Here in Canada, as elsewhere, cultural sensitivity and cultural competencies among service providers have been heralded as a way in which practitioners can gain an understanding of dominant health beliefs and practices of their client base, and has been promoted as a way of providing more effective migrant healthcare. This approach, however, has been critiqued for potentially reinforcing cultural stereotypes and for identifying culture as a decontextualized and singular barrier that needs to be breached in order to assimilate migrant patients. Access to healthcare services is also structured by multiple factors, including, again, migration status. Undocumented and uninsured workers may fear deportation or detention by health authorities. Labor migrants residing with employers may rely on them to access health services. And this is particularly problematic when I worked with migrant domestic workers living in rural households who were wholly dependent on their employers for transportation. In fact, it's underuse of healthcare, which is particularly problematic, often, again, due to restricted status, work environments, or lack of information. The efforts to introduce patient-centered care that highlight structural vulnerabilities and work across sectors, I think, to mitigate those vulnerabilities is certainly essential and something that I see as a positive move. Improving access to and developing the uptake of structurally competent healthcare services for migrant populations is, as I've noted, vital. However, improving the overall health and well-being of migrant populations requires us to move beyond healthcare. Migration policies that limit the possibilities of resettlement and family reunification, and or that tie migrants to a particular employer, especially in workplaces such as private households, maritime or agricultural settings where their movements are further constrained, contribute to precarity, and not only of work, but of lives, and which are associated with worsening health status. In fact, studies have found that the more restrictive the immigration policy, the worse the health outcomes. And I would maintain that an intersectional lens can help us understand how and why. In sum, what might intersectionality bring to migration and health? I think it helps us to highlight the legacy of the migratory journey, including the historical, political, economic, environmental, gendered, sexual, ethnic, and other factors that precipitated movements across borders. It can also illuminate social positioning of migrants and migrant communities within the host community. And again, that is not a singular proposition. These communities are themselves situated within host communities that are geographically and demographically different. So you might be in a rural area or a small city in an urban area, and the size and the composition of co-ethnic or diaspora communities can be different. So all of those, I think, are in consideration when we think about the various social landscapes that people inhabit. And all of them, again, are configured by the dynamic interactions of various social markers. Again, sexuality, age, gender, class, etc. All of which, in the context of the totality of the multiple contexts in which one lives, works, is engaged in family or community, has access to resources, is involved in transnational links, are all vitally important when we can think about intersectionality and how it is experienced. Again, all of these things coalesce and are experienced, interpreted, and responded to through the body. In other words, an intersectional approach attends to all of these issues within the context of power and oppression and other dynamics, as we see people and communities situated amongst and integrated with macro and mesolevel forces and institutions, and how those affect bodies of individuals and communities within historic and current contexts. All of this reflects, I think, the messiness of lived experience. So intersectionality allows us a more nuanced understanding of the complexities of problems that are presented and the identification of more appropriate solutions. So I think deploying intersectionality as a lens is critical to uncovering and subsequently remedying health disparities to work towards a goal of greater migrant health equity. So in conclusion, the magic words here, working towards this goal requires a broader focus, more decidedly an upstream processes that engender inequities. To this end, we need to, of course, deconstruct policy, practice, institutional silos in support of intersectoral, participatory, evidence-based policy, program, and decision-making. And these efforts might well inform migration policies that can address precarity, mobility, social protection, labor and political rights, all of which have salient health impacts. Canada requires immigration, and enabling newcomers to flourish enhances social cohesion and contributes to the project of nation building. More inclusive immigration policies and programs that facilitate migrants' integration into the host society are essential to improving health and well-being of migrants and to the society at large. Thinking intersectionally calls for treating migrants as individuals and as members of both global and local communities with both singular and shared histories, identities, strengths, hopes, and disadvantages. It involves rejecting the kind of paucity paradigm that views migrants as always a net deficit and demands use of synchronic and diachronic perspectives to further illuminate where we might go in the future. It acknowledges variation and movement and locates it requires collaboration across multiple borders and fields to realize, again, migrant health equity, which in turn leads, as I've said, to a more cohesive Canada. Thank you.